I am heading the INEX Data, which is the data AI center of Ichilov Tel Aviv Medical Center, in the 30 minutes that we have left until coffee. I'll have the honor of sharing my own perspective and the perspective of our distinguished guest, which I will introduce briefly, about our perspectives on what will, and here comes the word, AI, and data science. What are the potentials and what are the challenges in the transformation that this enables healthcare? Until 2 years ago, I knew nothing about healthcare. I knew a few things about data and data science. And so these pictures about the future looked quite trivial. It was only obvious that tech and data will enable healthcare transformation. This is a good picture of what we see today, and the challenge is that, yes, there is a huge abundance of data that is promising for how we do healthcare in the future. And as Dror Bean described in his short presentation, tech, and there's a lot of partners here, is giving amazing advancements. However, tech and industry tend to give solutions to very specific problems which have an effect that can, bring money into their organizations. And I find that in what has to do with workflow and the integration that has to be done in actual decision-making in the wards and in the hospitals, we're progressing very slowly. So today, in any part of the world, and we have a lot of international friends here, when patient goes into doctor, and at the end of the day, most of the decisions are taken upon the data about the specific patient, if available, and the knowledge and expertise of a specific doctor, which is nice. But in 2024, you ask yourself, but what about the data about millions of other patients, and excuse me, the doctors in the house? What about the knowledge and the expertise of millions of other doctors that can put together and bring us a better solution? That's far from being used in the way that it can be in 2024. And the result is the biggest challenge of the healthcare around the world, and that's the stress and the fatigue of the most important people other than our patients, and that's the healthcare providers. Skipping a few slides because I want to give my guest the time, but this is what we build INEX Data to do, and there's a lot of words. The important ones are applicable AI that can be put into the healthcare workflow. We're not writing papers. We're doing research only on things that we can find that will be applicable in our wards in a span of 2 to 3 years max, sometimes much less. And how do we do this? So we based our strategy on 4 pillars. The first and more important one is people. We can talk about revolution until the end of days. You need the right people, and what we've done in the last year and a half is built a team of experts in data science and data engineering and software engineering and product, people who didn't think they'd find themselves in a hospital, and people that a public hospital didn't think they would meet. And yes, as Dr. Oshman said, some of them were my officers 2 years before. And these people, together with a very combined effort with our amazing clinicians, are looking for the right challenges and the right solutions to these challenges. And this is the first and most important thing. The second pillar of our strategy is the platform. So when Professor Gamzo at the time told me, come and join Ichilov, he talked about AI. That's a very fun thing to talk about. You cannot do AI, no matter how much abundance of data there is, without having the data in the right format, in a multimodal fashion. So we rolled up our sleeves, we put AI aside for a moment, and we built together with our strategic partners from AWS a data platform, cloud-based, yes, cloud-based. I remind you, my background, it's not any more dangerous than what's happening on-prem. which brings together all the required data from the different modalities in a real-time and synchronized manner. Okay, now we can talk about AI. The next one is research. And again, since we're a bit late of schedule, I want to just give one example. Our first AI application that is today running in the internal wards of Tel Aviv Medical Center was a detect and prevent platform, a platform that was designed to detect deterioration of patients in the internal wards based on 80,000 retrospective cases. Great results to our model, that's nice. We then ran it as a silent prospective study in the in the wards. That means running on actual patients, more than 10,000 patients for more than 6 months. And again, very good results, a nice AUC. All that's nice, but this is the most important part of what we wanted to understand. We wanted to understand not if we're detecting or not detecting, is the algorithm good or not, but what is the added value that we're going to give to our clinicians. So just in a moment, there's a lot of numbers here, but I'll point out to the ones in the middle. Of 96 patients who deteriorated in 4 weeks, in which we asked 2 times a day, we asked the doctors, we gave them a list of their patients and asked them in the morning meeting and in the evening, who is going to deteriorate in your ward? This is 4 wards at the hospital. 22, I don't have a pointer, you see my pointer. 22 were detected by both doctors and algorithm. 10 were detected by doctors and not algorithm. Since then, we've understood some things about our algorithm, but 30 were detected by the algorithm and not by the doctors. And this is added value. Just to add, to be fair, we ran the algorithm when the doctors predicted, but the algorithm, unlike the doctors, predicts every 30 minutes on Shabbat and on Yom Kippur, and when the doctors are busy and when they're tired, so the number would be much larger. And if you ask the doctors, they don't really sit twice a day with a piece of paper and all their all the people in the wards and ask themselves who is going to deteriorate. So the number 30 would grow even more. So this is the way to ask yourself, not scientifically if this is a good algorithm, but practically, is this going to save lives in the hospital or not? And this is the way we do our research. And last but not least, the application. So anybody who's been in a clinical ward knows that when you come up to a doctor with a great new invention, they will first ask you, how are we going to be able to utilize this? In Israel, at least, if it's another system, no matter how many lives it's going to save, they're not going to take it because they cannot. And building the applications, be it Gen AI or be it simple data that is provided to them in a manner that will assist them in decision making, if it's not integrated correctly in the existing workflow, it will not work. So that's the last part of a strategy that says, from people, through platform, through science, but up to the application, we need to ask the clinicians what it is they need in order to save lives, and this is what we have the honor to do in Tel Aviv Medical Center. So with that, I'm happy to introduce our distinguished guest today from New York, Dr. David Reich, who is the Chief Clinical Officer of Mount Sinai Health System and the President of Mount Sinai Hospital in Mount Sinai, Queens. Thank you.
Thank you so much. Let's see if I can figure out my presentation. I wanted to start by giving credit to colleagues that work with me. First of all, Robbie Freeman, I've been working with for about 8 years now, and he began as a nurse on the clinical floors, and I'm also here with Dr. Nick Gavin, our new Chief Medical Innovation Officer. And so these are not things that happen in a vacuum. They're all based upon teamwork. No disclosures relevant to this presentation. As you all know, we begin when we work on predictive models with historical clinical data, prototyping, and moving to a predictive engine. And similar to the slide that you saw from Liat just a few minutes ago, we're also very concerned about the platform. The platform is the architecture that underlies everything. So bringing data scientists together with clinical scientists and informaticists, this is the platform that supports most of the clinical decision support and other predictive analytics. But we've had to think differently recently and start to build a platform to support generative AI. And I want you to notice at the bottom, human feedback. Human feedback will come back into this discussion over and over again. Currently, we have about 17 products deployed in 6 hospitals and do about 15 million predictions a year. I agree with Liat. The nice thing is our algorithms don't get tired and don't need vacation. They don't even expect retirement benefits. So it's really a good thing for us to build ways to augment the intelligence of our providers, and I'll come back to that word again and again. A couple of examples. You already heard about clinical deterioration, so I'll just show the research study we did right up until the time of the pandemic. And if you'll notice, very much in the middle here, in the B section, we were able to actually comparing the algorithm that sent the rapid response team for clinical predictions of clinical deterioration to the patients, that we actually were able to decrease mortality compared to floors where we did not deploy the algorithm. And this has led to, as similar to what you see in Ichilov as well, that today we have a live system which deploys our team. The constant theme is to bring the right patient, well, actually I should say the right team to the right patient at the right time. I want to spend a little moment or two on malnutrition. It was our first major deployed algorithm, and the reason I'm showing you this is you heard a bit about that from Liat. Doctors are inherently skeptical. When I got married, my spouse basically said, several years before when we first got to know each other, your superhero name is Dr. Skeptical, because you don't believe anything anyone tells you at first. And it's challenging because in medicine we have so much propensity to cause harm that we have to worry very much about how things will help us do a better job. So in this case, the algorithm explains to the clinical dietitians why we think a patient has malnutrition. Why is that important? Well, malnutrition is really, really prevalent within hospitals. But the point about this is that the clinical dietitian sees the reasons why we predicted it, and then in their documentation in the medical record, they provide us with feedback. So we have reinforcement learning, which improves the algorithm iteratively. The second thing is an American political statement. All politics is local. Well, I would say all predictive analytics is local. We tried to use, from a major electronic health record provider, an algorithm to predict sepsis. It didn't work at all in our population. We ran it in the background. It was garbage in, garbage out. And when I spoke to the person who developed it, I said, well, maybe if you produce an algorithm on corn farmers in Nebraska, it doesn't work in the people in Manhattan. And he said, how did you know I used a Midwestern data set? And the answer, of course, was that I didn't. But in all of our implementations, we work very carefully to be certain that the algorithm works equally across the different campuses and across different populations. And we were able to triple the rate of diagnosis and, more importantly, the treatment of malnutrition, which improves the care of our patients. I want to go to delirium for a moment, not because there are so many different things we could predict that delirium is the most important, but the point is the tools have to evolve. We were fine with structured clinical data for predicting clinical deterioration. We were not fine with structured clinical data in predicting which patients were going to develop delirium in the hospital. For that, we needed natural language processing, so the tools had to evolve. And once we were able to do that, we took a not so amazing predictive algorithm, if you look at the reddish and the bluish lines on the right, and we got to something with an AUC of about 0.94, which is almost scary predictive, just by adding natural language processing of the reports of the physicians and of the nurses together. I would argue it would probably be even better if we included the social workers. So next, we move on to the problems. These are problems I have to solve. We have a problem in medicine throughout the world in that there is social injustice throughout the world, and we certainly see it in New York City. There are very wealthy people, there are very poor people, and Mount Sinai lives on the borderline. There is a zip code just above us, or I should say really to our south, the Upper East Side, very wealthy people. And we are in the zip code of East Harlem, very poor people. And when you look at the data, people have poorer access to healthcare and poorer outcomes when they have lower socioeconomic status. So we train our algorithms on biased data. And when we have the discriminatory data on the upper right, you have on the lower right biased AI design and deployment practices, which leads in the lower left to application injustices. So that is something that we have to work very carefully on the back end to test our algorithms and to intentionally look at different patient populations. The other thing I'm going to talk about is our data that came out of a group of radiologists. Now, I'm an anesthesiologist. No one's going to figure out how to intubate or do cardiac anesthesia anytime soon with AI or robotics. I think the radiologists, however, are scared incredibly that somehow they're going to be replaced. I think it's a misplaced fear. I think their abilities are going to be extended. So they did a little study where they intentionally introduced errors in an AI algorithm, and they had people look at mammograms, and then they had the mammograms on the lower left there. You see in orange the 12 mammograms compared to 28 where they gave proper predictions. And then what happened was fascinating. When we look at the left side, the AI is suggesting the correct diagnostic category for the mammography. And on the right, we have an introduction of incorrect predictions, and the residents and the reddish bar were wrong about 80% of the time when the algorithm led them astray. And the moderately experienced, newly graduated attendings were sort of in the middle, and even the experienced attendings were wrong half the time. So we take upon ourselves an obligation that whether you call it a mistake or a hallucination or some other term, we are, again, in a profession, in healthcare, where we have a propensity to cause harm. So if a predictive analytic algorithm is going to make a wrong prediction, that's on us. We hold the licenses, we took the oaths. Next, workflow. This is an example of nurses protesting in California against AI. Now, why hasn't that happened yet at Mount Sinai? It may very well someday, but I showed you before, my collaborator at the very beginning, Robbie Freeman, is an RN, a nurse. He started in the floors, and when we deploy our algorithms, we work with the local teams. So I'll go to another political statement. In the 1990s, there was a political commentator who said, well, how do you get to be elected as president? It's the economy, stupid. I would argue that for us, deploying advanced technology within healthcare, it's the workflow, stupid. I'm not calling you stupid, I'm not calling myself stupid. It's just an expression, but the point is, we take upon ourselves, again, an obligation to be focused, laser focused on the workflow and how we integrate our work there. Nurses spend 51% of their time documenting. How can we make their lives better? Well, certainly not by doubling their work and adding a lot of alerts that don't lead to effective interventions. So barriers are evolving, tech advances show promise. What does this mean? We are now confronting what generative AI means to our enterprise and how we're going to overcome the impediments on the left and focus on the technology advancements to the right. And although there are many different elements within this slide, I think that the point is it requires a reboot in our thinking. Predictive analytics in the days of logistic regression, moving to random forest, even to neural networks or other forms of deep learning, in some ways, they made sense to us. There was a little bit of a black box, and I explained why in the earlier phase of this that we used the tools of random forest to tell our dietitians why we made the prediction. But here in the age of generative AI, we take on a real problem because there are so many hallucinations. So how do we overcome that with governance? Governance is our latest obsession because not only do we have developments that come to us from outside Mount Sinai, tools that we develop inside, but we have to regulate the whole. I told you about the injustices of AI that are trained on biased data, and I also warned you about the challenges of not fitting things into the workflow. And this is the process. We are concerned with research, we're concerned with learning and discovery, and we're also concerned with clinical and operational. And so those are the three pillars, and within those, we've developed an AI governance lifestyle, beginning with pre-triage through a review process. We'll describe that as checkpoint 1, a validation phase, and then a checkpoint 2 prior to deployment, and checkpoint 3 regards the fact that you don't just implement something, you implement it and you monitor it, and you make sure that there's no drift, and you make sure that the accuracy is always there. So performance improvement and quality assurance have to be at the root of everything we do in medicine, and that applies also to the technology tools. So as we focus now on generative AI, we are considering care planning and shift summarization as another way of decreasing the burden on our employees. When we are thinking about the administrative work that we all do, the burden of email, and just think about it, when a doctor goes home at night in our health system, often after they deal with the family and the kids are to bed, we talk about the process of pajama time, which is closing the charts out and dealing with all of the messages. It's wonderful that our patients can leave us messages through the portal, but so many of them could be handled by some sort of bot. So many of them are related to refilling a medication, to establishing another appointment, to reassuring people about minor symptoms. And so reaching that level requires that we think about ways to decrease the burden and the burnout that Liat referred to. And so these are essentially the elements of how generative AI can revolutionize medicine and can decrease burnout. This is one example of a digital engagement tool that helps us probably decrease visits to the emergency department by having an AI-powered symptom checker, which is facing the consumer, not facing the doctor or the nurse, and in many cases helping our patients decide whether they need to come urgently to our facilities because we're concerned they have a life-threatening condition, or can direct them appropriately towards some sort of virtual care visit or perhaps a visit in a clinic in a few days. And the virtual assistant is very helpful at this point in engaging with our patients, in helping them refill their medications. The portal is, in so many ways, the most important part of our platform. The platform internally communicates with our staff, helps us do things more safely and effectively. But the virtual assistant faces outward, and that is really the latest and perhaps the most important effort that we have, is to interact with patients. I want to talk about one more thing that's very important: analysis of errors. Our analysis of errors is still very manual. Surgical residents, for example, spend time assigned to look at cases where there were surgical complications. And what we did was develop a tool to do chart review. And so the overview of that project is that we need somehow to identify and report surgical complications and to move away from relying strictly on frontline providers, because the frontline providers can miss things. These charts are massive. And the solution is to automate. And the goal, of course, is a comprehensive repository to reduce underreporting, but more importantly, to reduce time and effort. So what is the vision for the future? If you think about it, we are looking towards patients and consumers, towards our care team, towards supporting our workforce, towards educating our faculty and our students in creating new tools, and supporting our researchers in clinical trial matching, medical literature discovery. And I won't go in this talk into biomedical discovery per se. But the efforts have to be coordinated, and they have to be done in a way which is most effective. So that active pilot worked very nicely, and so I'm just going to end with what we learned. In everything we've done, it's more than the model. It's about co-designing with our teams. It's about agilely iterating, because you don't get it right the first time or even the second time. You can always improve. And then finally, it's about robust governance. Without governance, the whole thing becomes, I'll use a word I learned here, balagan, it becomes a mess. And so how do we prevent a mess? It's by having great governance. And the future is so bright because the data assets we have, when we mix genomic data with our imaging data, with our waveform data, our electronic health record data on one of the most diverse patient populations on earth, there is no barrier that we cannot solve in terms of personalizing medicine. And the technological power that we have here in Israel, combined with the data assets that we have in places like Mount Sinai, set up potent opportunities for collaboration. And I look forward to talking more about that with many of you in the days that we'll spend here. This is maybe my 20th visit to Israel since I was 16 years old. I'm no longer 16, but I really enjoy coming here. It's a wonderful place, and seeing how you've evolved, where the major export moved from oranges to tech, is a wonderful thing for me to see over my lifetime. And thank you so much for allowing me to say a few words to you.
So in interest of time, although I had a lot of questions to ask you, I want to ask just one. MIXiii is all about collaboration, and you referred to collaboration in the end. But I want to be a bit critical to ourselves. There's a lot of talk about collaboration, and there's beautiful things being done. But data isn't really being shared yet in a way that can really exploit big data. You discussed the difference in predictions for different places in the world, and I want to ask you about the future. How will algorithms and data sharing change the way that medicine can be done around the world, and what needs to happen in order to have the organizations truly be willing to share data for the benefit of our patients?
I'd say the problem is that we live in a world where we have regulatory barriers to sharing data. One of the things that is of greatest concern to me is that the genomic data that we have, Mount Sinai currently has 300,000 genomes in our database, and will soon have 1 million. I can't share that data with anyone outside of Mount Sinai because there is no such thing as a de-identified genomic data once you get past a certain point. So how do we do that? We need governments to create safe harbors for us to create those massive repositories. You might think of it as a CERN for medicine, in a sense. Because how do we work with industry to use the massive computing power that we have and talents outside of medicine to do that? It's only going to be with that. I think Europe has a bigger problem with GDPR than we do in the US, but still in the US that is a tremendous problem. And so I think it's about advocacy. It's about saying to governments that we have an opportunity here to do things that we could never do before. And as we balance the interests of privacy, which are extraordinarily important, with the balance of creating biomedical discovery, which is also of great importance, where does that balance lie? And so I think it's incumbent upon all of us to advocate for that.
Wow, so much more to hear from you, David. Thank you again for coming to Israel for the, I don't remember how many, 20th time.
I lost count, but that's a good thing.
Oh, we appreciate it. And with that, thank you.